Hi, today I'll be talking about cluster headaches. More specifically, I'll introduce you to what they are and how they are caused, discuss current treatment methods, and run you through recent breakthroughs in cluster-specific research, which could potentially lead to the development of drugs and devices that could be the first effective means of treatment for this physiological condition. First, I'm going to start off with a more relatable and common condition, migraines. Migraines can be described as a severe headache accompanied by sensory disturbances such as disturbed vision, sensitivity to light, and vomiting. Migraines can last for hours at a time and affect millions of people around the world. So I'm sure many of those in the audience have either experienced this condition themselves or at least know someone who does. So if I tell you that in comparison to a cluster headache, a migraine is a mere annoyance, I want you to understand my full meaning. A cluster headache is a rare, extraordinarily painful, and chronic condition affecting 1 in 1,000 people. Commonly referred to as a suicide headache, the pain it causes has been known to drive people to suicidal thoughts. The term cluster is used to describe the nature of this affliction, where attacks usually occur 1 to 8 times a day in a cluster of weeks a few times a year, where these clusters occur at the same time each year. Symptoms include severe pain around one eye, pain isolated to one side of the face, a running nose, and a drooping eyelid. Current curative measures for cluster headaches are mediocre at best. For example, some patients experience a large pain reduction for approximately 15 minutes when being treated with triptans, such as sumatriptan. Triptans are part of the tryptamine drug family, usually being injected into subcutaneous tissue. The disadvantages of triptans severely outweigh the benefits, where there is little known about how they work, and they cannot be used to treat those who suffer from cardiovascular disease, or even those who have a history of cardiovascular disease in their family, thus meaning that 1 in 6 Australians cannot be treated with these drugs. The aforementioned treatments do not prevent cluster headaches because they don't target the mechanism by which they occur. Recent research has hypothesized that the activation of the trigeminal vascular reflex, home to the neurons that innervate cerebral blood vessels, could be responsible for the severe pain found in the trigeminal nerve. Where seen in this image here, the trigeminal nerve extends into 3 different zones of the face. However, this does not describe the rhythmicity and clustering of these headaches, where the hypothalamus has been thought to play a role in this very distinct characteristic. It was also hypothesized that neuropeptides, small polypeptide chains that act as neurotransmitters, could play a role in the pathophysiology of cluster headaches. There is new data relating to the blocking of the calcitonin gene-related peptide, which is a potent neuropeptide in the trigeminal system. Evidence to support this hypothesis includes increased calcitonin gene-related peptide levels in blood and saliva during a cluster attack compared to baseline levels in the same patient. Seen here, blocking of the calcitonin gene-related peptide inhibits pain transmission, inhibits vasodilation of the cerebral blood vessels, and blocks neurogenic inflammation. Fromazenumab and galcanezumab are 2 promising new drugs that use monoclonal antibodies to block the calcitonin gene-related peptide from binding to neuroreceptors, where, as seen in this image here, the calcitonin gene-related peptide acts as the antigen to these antibodies. Now, this research is still ongoing. Another promising avenue of treatment exists in that of the neuromodulation of the vagus nerve, which is the 10th cranial nerve. Successful treatment of cluster headaches has been deduced to be a downstream effect from the nucleus tractus solitarius, which is a structure that inputs from the vagus nerve. Via the nucleus tractus solitarius, stimulation of the vagus nerve has been thought to have either activating or inhibiting effects on the trigeminal nucleus cordelia and the hypothalamus. This is supported by the recent mechanism discoveries I mentioned previously, and a 64% improvement in cluster patients following hypothalamic deep brain stimulation. Recently approved by the FDA, GammaCore is a preventative, non-invasive, and handheld neuromodulator, where when applied at the neck, stimulates the vagus nerve. In a 4-week trial of 45 patients, cluster patients experienced a reduction in attacks per week from 5.9 to 2.1. However, gammaCore does not reduce the severity of each attack, merely the frequency at which they occur, thus being a promising form of treatment with much room to improve. In conclusion, we now have 2 promising avenues of treatment for cluster headaches, where it's hoped that more research can be used to improve the quality of life of these patients. Thank you for listening.